Hello, that's great. Hi everyone, good evening. Thanks for joining me, wherever you are in the world tonight. It's lovely that you've joined me. So what I'm going to be doing this evening and talking about is immediate dentures and how I actually make them. So now, it's really practical. That's all I really like talking about, is actually how to do this sort of stuff, because this is what I do in my everyday life. So please, and if you have any questions at all, put them straight into chat there, and then I'll revisit them later on once we've done the presentation. So let's get on with it, and let's have a look. This is Donna. Now, some of you may have seen this patient before and what I actually did for her. However, I've included the actual process of taking the impressions for Donna in this for this evening, specifically because this is about immediate dentures. So Donna presented to me a few years ago. She was in her mid-40s and ever so embarrassed about her teeth. She did not like being out in public and was really quite introvert socially because of her teeth. They'd started to drift, periodontally drift. Let's have a look at the X-ray picture here. So now she got, and this is according to the new classification of periodontal disease, generalized periodontitis, which is stage 4, which means it was really severe. Grade C, which means it's progressing rapidly, because of her age. She's in her mid-40s and got virtually no bone support left on those upper teeth. So I just do not like taking teeth out at all. I think natural teeth are wonderful and I want to keep them. But sometimes we just have no choice. So I felt that these teeth needed to come out, and we really needed to stabilize this process. The prognosis for those teeth that I've marked with X was hopeless. So the first phase of treatment for Donna was this, which is the stabilization phase. And so I chatted through her the whole of this process. I was going to provide a full upper acrylic-based immediate denture, and in the lower arch, a lower partial denture. I'd do that in one go, so we'd take an impression and then fit. And then my colleague, Saeed, who's a periodontal specialist, would then get to work and help Donna to manage the periodontal disease for the remaining teeth that had a better prognosis. Now, I gave Donna this treatment plan, and I didn't see her for almost 2 years. And this is how she looked when she came back. Because my fees are high. I'm expensive. It's a small, exclusive practice. Anyway, with that passage of time, that upper central had dropped out, exfoliated, and also the lower right central incisor had come out too. And she'd had this little tiny acrylic denture fitted just here, and that was wedged in. She couldn't even get that out. But anyway, she was ready for treatment. She'd saved up enough money to proceed with the treatment, and she was psychologically ready to have the upper clearance and the lower partial denture done. Now, my job at this point is to give Rowan some superb impressions of the mouth on which he can then cast a model and then produce a superb denture. So let's have a look at the impressions that I did for her. Now, if you've been watching the webinar series, you'll know that I really love, for primary impressions, this 2-part technique where we have a runny material, a light-bodied alginate, which I squirt into the sulcus, and then a base material which is placed in the tray. So, and this is the key to superb dentures. And this is the material that I like to use. So the base material is Alginate, and the runny injectable material is neocolloid. So let's now, I want you to just sort of imagine that Donna is sitting in the chair in your surgery now. This is what I do at this point. This is for visit one, for treatment visit one, for taking those impressions. I want to know that if I do an impression and we've got wobbly teeth, mobile teeth, I don't want them to come out in the impression. So I go around each tooth and check all of them and pull on them. And I was confident for Donna that taking an alginate impression would not pull out any of her teeth just by checking them like that. In some circumstances, I know that the impression will do that, and I want to share with you that technique later. But I just want to share with you how I managed Donna to start off with. So it's like I've been showing you over the past few weeks here. That's not Donna in the chair, but if you imagine that is Donna there, this is what we do. So Claire, my nurse, mixes up the runny material, the injectable neocolloid. So she mixes up that beautifully, and so as free of air bubbles as possible, and then she loads that syringe. And the syringe is, it's a monoject syringe, and it's a 35 milliliter syringe there. You can see it here. And I load my tray. So if you imagine this was an upper tray here for Donna, so I load that, and I'm actually thinking about where I want the impression material to go. You know, if we've got a big vault of a pallet, I want to get it around the back of the tuberosities. I am really trying to think about a mental map of the whole of the mouth there. And what I do now is I run water just onto the top of that and shape it up. I'm glazing it, and then we pop over to the mouth, to the patient, and Claire pulls the lip forward, and then I can get in there like this. I want to take you now to Donna here. So here she is. So I'm going to do the upper impression, and I'm thinking about the sulcus. I want to get this injectable material right around the back of the tuberosity. You can see I'm going right the way round, up into the sulcus, all the way round to that back tooth, right into the tuberosity there. And I'm talking to Donna the whole time. Claire's got these lovely little lip retractors in place. These are photographic retractors that we've just cut down, and they're beautiful for lifting the lip out of the way. I've got my base material prepared there, and I'm going to now put this into the mouth. I'm talking to Donna now. I'm saying, and I'm actually saying, I'm just rotating the tray in. I'm going to seat it up at the back of your mouth first. You breathe deeply through your nose, Donna, nice and deeply. And then I push that up at the front. Claire, just lift those retractors out of the way. And then I just gently just feed the impression material just by massaging the lips, feed the material up into the sulcus. So I'm recording that full depth of the sulcus, but I'm using a hypnotic voice for Donna while we're doing this, just to help her. And then I count it down with a stopwatch. When it's set, when it goes to 0, I then take it out like this. So here's Donna. I'm going to remove the impression now. Can you see Claire has automatically, and this is not what I've asked her to do, this is just like a natural response of caring. Claire just puts her hand on her shoulder, Donna, just to reassure her, because Donna is going to be worried that I'm potentially going to pull out some of these teeth. And, you know, it's not very nice. But what I'm doing is I am thinking about pulling that tray down the long axis of the teeth, drawing it down and just giving it a little wiggle, getting my fingers around the border and just pulling it down quite firmly along those long axes of the teeth there. And Claire's just reassuring you. It's just constant reassurance that we give the patient. It's really important to help them remain relaxed. Notice also that the patient's sitting up at this, you know, having the impression done. The other thing that I do have in the surgery is a knee break chair. So the patient's knees are down, and it means I can actually get in front of the patient. It helps me with these impressions too. So this is these are the actual impressions for Donna that we took out there. You can see them. It's got everything on that Rowan needs to produce a superb immediate denture. And also, if you look at the borders there, it is, at this point, it really is unnecessary for me to do a second impression, a definitive impression with a special tray. I wouldn't get any better detail. So from this, we make the immediate dentures. But I just want to do a little tiny segue now, and I'll come back to Donna just in a second. If I have a patient like I saw just before we had lockdown, COVID lockdown, this is Anne. Anne had, and I've actually done the impressions for this lady, Anne, for her immediate denture. These two teeth here, super wobbly. And without a doubt, even in an alginate, I'd just pull those teeth out in the impression. So what I do in these circumstances, I just put a little bit of Vaseline on the teeth, just a light layer with my finger, gloved finger, and then put Futar D into that area. This is the bite registration material, but I use a fine tip on my injector, squirt that Futar D in there, let the lip rest over the teeth and just gently massage the lip, and that creates that lovely smooth finish here. And when that sets, I then can do an impression over the top of it, but blocking out like that stops the teeth from getting pulled out in the impression. And this is the actual impression for that lady, Anne. And the nice thing is that when we do this with the Futar D, I can give this to Rowan, the Futar here, and he can then super glue that back into the impression, you know, using super glue, and it works really nicely. And the model produced is lovely. You've got all of the teeth on that, so then Rowan can just section the teeth off the model. It's great. So, hi Daniela, I noticed you raised your hand. If you have any questions, just pop them into chat, and I'll revisit them right at the end. So I'm going to go back. We'll get back to Donna now. Now, when I'm making immediate dentures in these circumstances like this, I record the occlusion in intercuspal position or maximum intercuspal position, MIP or ICP. I find that recording centric relation or retruded contact position is very difficult with super wobbly teeth. So the immediate dentures I make in ICP, my definitive dentures always in centric relation if it's a complete denture or we've completely reorganized the scheme. Very important. So that's Futar D there. And then, so Rowan's got those impressions, he's got the bite, and then he's ready then to make the denture. Let's have a look at the denture he made. And this is the full upper here for Donna, and then that lower acrylic based partial. So these are the temporary dentures. These are Shotlander Enigma Life teeth. They're just beautiful, really natural looking artificial teeth that we have. The gum work is lovely and coloured, but look how brave Rowan's been with the tooth positions. He's put those canines in the lateral position. That's because that's how Donna looked. So prior to the periodontal drifting that we've got on the left-hand side, on the right-hand side, we've got Donna there with a natural smile. And this is before the teeth drifted. Look at those canines in the lateral positions. That's what we copied. That is, and we just talked to the patient and we asked them what they want. Do you want this back? And Donna said, yes. So that's so exciting. It's lovely. So this is what we did for her. And this is Donna 1 week after fitting the complete upper denture and that lower partial. That's 1 week after. And it's just so nice. You know, it's lovely how Rowan has been so brave with this. And I absolutely love doing it because it changed. You can see in Donna's eyes, you can see in her eyes, it's changed her life. It really is transformational. She was then able to take her boy to school, do the morning drop off without any embarrassment, and she can just chat away to her friends and changed her life. She got a new job. She started open water swimming, and really the whole thing is lovely. And it's just a denture. There's no implants. It's just a denture. It's lovely. So now I just want to just share with you a couple of tips now. So when we have the patient, if we go back to the extraction visit and the fit visit of the denture, I want to make that denture as comfortable as possible. And, you know, when we've taken the teeth out there, it's so easy for the denture to rub. It tends to rub in these buccal areas around here, in that sort of undercut area. So what I do is, with the patient there, this happens to be Anne. It's a different patient to Donna, but we've just taken those upper front teeth out. What I do is I put inside the fitting surface of the denture here some light-bodied silicone impression material. This is Doric Flow. It's any PVS material that you'd use for your crown and bridge work. I just flow it in, and then I seat it in the mouth like this. So we take it to Anne, gently rotating. Now remember, Anne's totally numb. The local anaesthetic's in there, so she can't feel anything. So she wouldn't be able to tell me whether it was rubbing or not, and it would be a good few hours before she could tell me. So this just gives me an idea. So I push the denture in place. This is a full upper, push it in place, take it out, and I look for specific areas where it's rubbed off. I'm not concerned about it pushing through on the palates here. That's absolutely fine. But if it rubs off on these buccal areas, these labial surfaces, then what I do is I use a pencil and draw onto the areas that have pushed through, because this is a fit check of the denture. Draw on that, and then because I've not used adhesive, I can peel off that silicone, and then I can adjust those spots really carefully, and I can repeat that until we've got a nice, very thin layer of the silicone impression material, meaning the denture is fitting nicely. And doing this really helps with reducing the sore spots. So I just go to those spots with a tungsten carbide drill, and then we just repeat it until it's a nice even layer. So that's number one. Now, another top tip at review, if we've got severe ulceration, which we often have, and we have to check the occlusion, this is important. That's really important. But also, it's often the denture rubbing on the ridge. So if we now fast forward 1 week later, so we've got a patient in for review after fitting an immediate denture, the patient will have been wearing this for 24/7, apart from taking it out for meals and cleaning. So it will often rub, and an upper will often rub on these labial surfaces here where we get swelling and things. So if we have an ulcer, what I do is I dry the ulcer. You can see I've got just there, I've got a gauze. I dry the ulcer like that. Claire passes some PIP, pressure indicator paste, which I apply directly to the dried ulcer. Claire passes me the denture. I seat the dried denture in place firmly, back into place. It's a bit sore when you do this. Take out the denture, and then what shows up is the ulcered area is picked up in the fitting surface of the impression like that. And then I use my tungsten carbide to adjust it, to make it comfortable. It always feels a little bit uncomfortable, even after adjusting it, but it should feel better. That's my policy. But also, don't forget the occlusion. It's really important. You've got nice, even occlusion on both sides with the patient biting together. So I'm really fortunate in having two superb technicians that I work with. I've worked with Rowan for the past 20 years, and any younger dentists out there, I recommend, if you want to do this type of work, find a young technician, same age as you, and then you can grow with them. I've also got Sam, who's joined us as our apprentice technician, and he's learning from Rowan, and he is so talented. And Sam's dad works down the road in Chorley and makes our chromes. He's called Chris Hesketh, and he's terrific too. So having a great team is really important. Now, this presentation, you can download it from my website. It's at finlaysutton.co.uk. Go to the speaking page, please, and then scroll down, and you'll find tonight's presentation on there, how to give your patients superb immediate dentures. So that's a PDF form. So you could actually then, if you want to talk to your technician about different designs and things, you can actually do that. And I will be uploading this to YouTube and Facebook tomorrow as well. So now I want to move on to something a bit more extreme, really. So this is Joe. Now Joe had his upper teeth was shot, were just needed to come out, massive bone loss. In the lower arch, the two back teeth, one on either side, also needed to come out. They had hopeless prognosis. He'd also previously, you can see a wire at the front there, he'd had orthodontic treatment in the past to align his teeth. But that tooth, the upper left central, had exfoliated on its own. Now, some of these upper teeth were so totally mobile that I was scared about doing an impression, a normal impression. If I'd done an impression like I did for Donna, then it'd be highly likely I'd pull out some of these upper teeth. So this is where I've got to think laterally about doing the impression. So this is how I do it. So I take an impression tray, a normal stock tray of the right size. These are called Pegasus trays. They're fantastic. They're on you can just download the list of materials and equipment from our website. But what I do is I put red cake compound in the center, and that helps me locate it on the palate. That's like a palatal stop. But notice, if you look closely, I've actually trimmed the labial edge off the outside of that tray. So it's flat at the front here, like this. I'm going to take this to the mouth now. So that red cake is soft. Here's Joe. And we're going to do that impression. Look here. Rotate it in. Sit it up on the palate. Rotate it up till it's just shy of touching the teeth. So that's part one. And then secondly, I take that out of the mouth and then I load the tray with dense ply blueprint alginate. It's a firm mix, it's a medium to firm mix, and glaze it. And then I then come to the mouth with this. So this is it here. I'm going to show you the video. So on my finger, I've got a little bit of the alginate and I'm going to rub it into the occlusal surfaces of the teeth. So it helps us to get good occlusal detail. I then pick the tray up with the alginate in here. It's glazed. And I rotate this in, sit it up at the back. That's what I'm talking to Joe about. Breathe through your nose, wiggle your toes, and push that tray up so that that red compound acts as a stop. And I'm also being very conscious about pushing the material away from the labial surfaces of the teeth there. I'm getting Joe to waggle his jaw as well here, just to give the coronoid a bit of space. So what I'm trying to do here is just to capture a good impression of the palate and the occlusal surfaces of the teeth. I'm not bothered about the labial surfaces of the teeth, because if the impression material went on the outside of those teeth, it's liable to pull some of them out. So that's number one, part one of the impression. I then take it out carefully, like this. And then what I do is I cut in a little groove here, a little groove here, and if I can, another groove on the other side. And this is helpful for the second part of the impression, and it'll make sense just in a minute. Pop this into the mouth. I've got some heavy-bodied silicone impression material in a mixing gun. So this is called Doric Heavy. It's a heavy-bodied silicone impression material which I squirt in into the sulcus. I've made sure, though, prior to that, that tray with the alginate is fully seated back in place. I've got to push it up with my finger properly. So I feed this into the sulcus all the way round, using plenty of it. So loads of it. And then I massage Joe's lips. So it just feeds beautifully right up into that area. And then I wait for that to set properly. And then I take this out. So I take out the bottom, the underside first. The alginate there. That comes out. There. To clear. And then what I do is carefully take that outside portion. And doesn't it look a mess at this moment? It looks really untidy. But don't worry, it all fits into place. So we have these two parts here. So we've got the alginate and the silicone. And then what Rowan does when he gets it through in the lab, he dries the alginate and then sticks them together with super glue. He uses super glue all the time in the lab. It's fantastic. But look at it. Isn't that a great impression? You know, it's recorded everything we need to produce a superb immediate denture. And this is the cast that we can pour from that. It's got everything on it, a great sulcus. We then mount that in intercuspal position using our bite, Futile D bite. And then we then look at this and we think, where are we going to put the teeth? Which teeth are in the right place, which aren't? And we use photographs to do this, and it's great. So Rowan We just line things up. We put them back where they should be. So he's got a full upper and a lower partial there. Now this lower partial, again, this is just a temporary denture. We're going to make a chrome in a minute, in a few months' time, and I'll show you that in a minute. It's got 0.9 millimeter stainless steel wrought clasps. These work really well, and we just embed those into the acrylic. So let's now fast forward to treatment visit 2, which is when Joe is going to have the teeth out. So we take the teeth out. I don't like this phase, actually. It's not very nice, numbing them up and taking them all out. But needs must in these circumstances, unfortunately. And then with the denture, I quite often use, in about 50% of cases, I use a Visco Gel Realign. Now this is a soft material. Co-soft would work equally well. And this helps to make the denture fit really well over where we've taken the teeth out. So, and how I use Visco Gel is like this, is before doing the Visco Gel Realign, I put a layer of wax just on the outside of the denture, just a sheet of wax, keeping it free of the periphery all the way around. And this is brilliant because when I put the Visco Gel in the mouth, seat the denture and border mold, the Visco Gel comes over the top like this, and it stops it going into all these interdental embrasures. It makes the cleanup superbly easy afterwards. And I trim the Visco Gel with a blade actually afterwards, a scalpel blade. But we pop that in. That's the Visco Gel in the fitting surface. It's got the wax on the outside. Pop that in, do all of that, and then take it out and clean it up. And it comes up like this. It's really good. So that layer of wax is a really useful tip, and it'll save you loads of time if you don't do it already. So this is it at the fit appointment. And then he goes away and comes back a week later. And there we have him at 1 week later. Now, Joe was really, if you look at the upper immediate there, he was really conscious. He was very specific. He said, Finn, I do not want my clients knowing that this is a denture. I want to have like a little bit of chipping, some staining, teeth. So if you look here, that upper 6, he wanted that out there. So we talked about it with him before. And so that's him with his immediates in place. If you know, let's focus. I don't like clasps on dentures because they're ugly. They really detract from the appearance. But this is the stainless steel one. When we came to do the definitive denture, we did it with little gold clasps on, which just looked better and less visible. Plus, when he'd had his periodontal treatment, those lower anterior teeth were longer, so we could take the clasp down a little bit lower. Now, just want, on the back of the webinars that we've been doing over the past few weeks, I'd like you just to think about if you had Joe in the chair now and you were going to design the metal-based denture for him, his definitive denture, which we make 9 to 12 months later, what would you do for him in this situation? So I reckon you'll have a good idea of this, what I like, which is a Scandinavian approach here with lovely metal backings on a lovely dental bar supported by those anterior teeth, a nice chunky lingual bar, 2 clasps per denture, gold clasps, fully extended up the saddles, right over the retromolar pad and open to the environment. But these composite rest seats are fabulous. They're truly brilliant. You can see this is his model here. They just go on the back of the teeth there, and these act like little rest seats, like for holding the denture to stop it from going backwards and down, touching lots of surfaces of the teeth. And these are really so good. You can press on these saddles and the denture just doesn't move. It's superb, really lovely. And these are his definitive dentures that we fitted 12 months after extracting the teeth. I'd like to just share with you the upper left-hand picture, which is the upper denture at the moment. That's got a metal base inside it that looks like that. And it's got an acrylic post down on it too. I love these metal bases because what I don't like is my patient coming back with a crack in the denture. And Rowan and I have learnt the hard way. You know, we used to just make dentures acrylic based, and then, you know, patients were paying a lot of money, and they were not happy when they cracked. So this is a great solution to that. We can talk about that later if you have any questions at the end today. So that's the lower there as well in place, beautifully extended. And here he is, Joe, sorted at the end of treatment with a lovely set of dentures that he can eat with. Can eat, seriously, he can eat anything, and he's not embarrassed about it at all. And he's had his periodontal treatment with periodontal surgery on those lower anteriors by Saeed. It's all nice and stable now, and he's just a happier man. So now, so this is my basic protocol for immediate dentures here, and so this is the steps that I take. So at extraction, I will often use Visco Gel in about 50% of cases. So you can use Co-Soft if you can't get Visco Gel. 2 months later, I reline the immediate denture with a hard plastic material called Ufi Gel. There's lots of different types on the market. They all work beautifully. 4 months after extracting the teeth, I then do a lab reline where Rowan relines the inside of the denture. And he does that quickly. He gets it in the morning at 10 o'clock, and then I fit it at 4 o'clock. And he relines it with a cold cure. It's called Pegasus. It's made by Shotlander material. And then with all of my patients, they are all tied in. This is all part of the whole process, tied into having a definitive denture made at a minimum of 9 months, but I like to take it further forward than that at 12 months, just so we get as much resorption out of the way as possible. So I'm going to bring all of this together now with Wendy here. So I'm going to show you step by step this approach. So Wendy's here. She's got this inflammation on these upper anterior crowns. They're not fitting well. She's got a deep overbite. She hates this aesthetic appearance. You can notice she's got apicectomy scars here, and she's chipping the ceramic on these upper teeth. Some of these upper posterior teeth are heavily restored too, which is really quite important just to note. But again, it's like, you know, if we went in there and did restorations on those back teeth, it makes it very expensive, the whole thing. But let's have a look at these front teeth. This was her concern. She's got apicectomies on all of these upper incisors, but look at that, areas on all of those teeth at the top there. And big gaps. What do we do? Do we restore them again? I went through all the options. These are the options that I gave for Beverly here. Was we could strip everything down, re-endo, and put new posts in. Fragile masterpieces, liable to fail. Number 2, do we take them out and put implants in and a bridge, or separate crowns and implants? Or do we do a denture? She went away and thought about those options, and then she came back to me and said, Finn, I want to have the denture, please, after discussion. So we're now ready to do the immediate denture. So just think about this. If she was in the chair, what would your immediate denture be like? What design would it be like? This is the design that I used for Wendy. And the main thing is, the main real thing to look at is I always collet my immediate dentures. I find that the support and the stability is much better if I collet them, and also patient acceptance. So let's now go to the impression. So it's a two-part impression, like I just showed with Donna. And this is what I give Rowan here. So we've got our upper impression, lower impression opposing cast, and our intermaxillary record in FUTRD. Models get mounted, and then Rowan takes the teeth off carefully, just like you'd be having, say, if we were doing resin bonded crowns on those. So we take off the teeth, preserving the papilla, and then trim in 5 millimeters into the socket. So just making bullet shapes, ovates. The denture fits in. It's lovely. And if you look here at the denture, Rowan's put gum work here and here, because once I've taken the teeth out, I never know where that gum level is going to be. And I don't want a big black triangle if we take the teeth out. So that's the denture itself there. Colleted, 2 ball-ended clasps, superb. And you can see we've put the pin dam in and at the back, and then we've also socket fitted those too. Let's go to the fit visit, treatment 2. Here we are. I've taken the teeth out carefully. Now notice there's very little space there when she's biting together. The denture has to be thickened up in that area with acrylic. So we do open the bite up a little bit. That is just something that we have to do in these circumstances, particularly with a deep overbite like this, class 2, division 2. Luxators, carefully removed those. I used director luxators to take the teeth out, lovely and sharp, getting down into the periodontium. Lift that out. And then here's the denture. Now, this is top tip. If you are new to dentistry and a younger, dental, just qualified, this is brilliant. This is going to make your life amazing. This is how to adjust a denture. Is, if you notice here, I've put down here, never adjust here, as this will create a gap along this border. So where the denture touches the tooth, please avoid touching that area and adjusting it. Only adjust above that area. And I'll show you exactly how to do that. It's using Occlude. Occlude is fantastic, this spray that's a powder, and I spray it onto the fitting surface of the denture and then take that to the mouth. And if the denture's not seating, I try and rock it into place. If it's not seating, then I use this type of a burr, a crown prep burr, and adjust these marks where it's rubbed off. But I avoid touching this border here. And this means that my dentures fit like this. Here's Wendy's denture. Seriously, if you looked at any of my dentures, they all fit beautifully around the neck. So that will really help you when you get back into practice, that little tip. And there we are. It's all fitted down nicely. And that's now, I know some of you will be thinking, oh, Flip, look at the teeth, they're too white. I know that you're absolutely dead right. I wanted to make them slightly darker, but this is what Wendy wanted. And I always do what the patient wants. It's fine. It's their choice with this, with aesthetics. It's their choice totally with aesthetics. So now let's fast forward 2 months. Look at the shrinkage occurring where the denture's not fitting against the ridge. It's all starting to shrink away. So we need to do a chairside reline at this point. I want to show you how I do that with UV gel now. So how I do it is on the denture, just like I showed with Joe, I block out the front teeth there, and then just put UV gel into the saddle and then fit that into the mouth. And then what I do is, whilst it's setting, this is really important, whilst it's setting, so it doesn't lock in, I move it in and out of the mouth like this. But you know what? About 18 months ago, I was doing exactly the same thing for a patient as I was doing for Wendy there, and I forgot to move it in and out. And here is Diane with it stuck in the mouth. I just fitted it and I didn't move it in and out. What an idiot schoolboy error here. And so it took me an hour and a half to cut it free. I had a patient waiting, you know, in the lounge outside. But I had to cut it out using my diamond crown prep burr just to cut around that flange to get it out. You can see my cheeks going red. I'm really stressed. Diane was fine about it though. She's absolutely fine. So, but seriously, I don't want to scare you about this at all. But as long as you move it in and out, it's absolutely fine. It works fine. Just follow the manufacturer's instructions. So here we are. Can we still get it out? Is it coming? Hooray! We've done it. So, what a wally. Here we go. So that's, this is back to Wendy now with the UFI gel. All that does, it looks a little bit scruffy there, but it just disguises where we've got the resorption and just looks miles better actually when she left. So, because we've got a really gummy smile, really high smile. So now let's fast forward 4 months. By this stage, a lot more resorption has taken place. So this is why I do a lab reline at this point. And this is really straightforward to do. I do a silicone impression within the saddle of that area. You could use zinc oxide actually for this. It's absolutely fine. Just anything to fill that space. I take this out. Now, this is a really important detail here. Now, if you look closely here, I take a scalpel blade and I cut away this section away from that collet. It's in the same way as when I'm adjusting the denture, I remove that so that is totally free now. And that means that Rowan is not going to add material in that area. He's not going to add plastic to the denture there. I then put this back in the mouth like this. And then I seat the denture back in the mouth. And then I fill a stock tray with alginate and push it over. Let that set. And I pick up the denture. And this goes through to Rowan now. And then he gives it me back at the end of the day, once he's relined it. So he relines that. So he pours a lovely model in this like this. Superb. And then relines that flange and makes this denture future proof until we can then do the definitive. But look at it, it's way better. And this flange starts to help with the retention too. It's really good. So that's the immediate there. Now she's in a good holding pattern, ready for a denture later on down the line. So this is the immediate in place. We've got this, look at that beautiful flange fitting. It looks great, you know, you can't see that join. And then if we now fast forward 9 months from this point, here we go. We're now ready to make Mark II, the definitive. Now, this was a really interesting design that we used. Now, this is really, really important here. We've got heavily restored posterior teeth. I don't know how long they're going to last. It's expensive to restore those, to put onlays on and to get those back into good shape. It really is. It's expensive. Certainly, if I was going to do that, it'd be at least £2,000 per tooth, and this would increase the cost massively. So, I often do this. It's a different type of design. You may not have seen this before, but it works beautifully for heavily restored posterior teeth. It's a denture stroke splint. We have metal occlusal surfaces on those upper teeth, and the patient bites onto the occlusal surfaces. If you look at the bottom here, we've got really a lovely path of insertion, just like this, which means that this aesthetic arrangement, that once we finish the denture, we've got the flange just blends in beautifully with the gingivae. And then the other thing is we've got 2 clasps per denture. Where I've put these X's, that's where we get retention. And so we've got a occlusally approaching clasp at the back there. So on upper dentures, I want the clasps as far back as possible. I'll show you this, how we actually go through this process. So impression, this is a special tray, Alginate, beautiful. Look at the detail in there, the teeth. Now, when I'm doing something extensive and altering the occlusion, I want to try something in before I actually make the chrome. So I use this. This is a mock-up in pattern resin. So we'll take this mock-up to the mouth and check it. And it helps me for 3 things. Number 1, it helps give me assurance that the definitive working cast is accurate. It's not totally foolproof, but it just helps me. Secondly, I can assess the occlusion. This is really, really important. I want, when the patient occludes together, for her to have even contact when she touches together on all of the teeth. And I can also just check that we've got canine guidance on it. Mutually protected occlusion. And also the third thing about doing this mock-up is that the patient can look at it and they can see if they can see red, they know that that's going to be metal, so they can actually visually assess how the denture is going to be before we get around to making this expensive. And also a lot of work has to go into these to make them. So this is the protective splint here. Superb. Scandinavian design. You can get TPs in between. Works beautifully. So robust. And it just fits lovely. So here we've got the mounted models. These are the working cast, the working upper cast. That's the pin set at 0. Just look at when I actually put the metal framework on, it opens the bite 2 millimeters there, and we've got a lovely even occlusion on that. I try this back into the mouth. Once we've had the chrome made, we check it, making sure it fits perfectly, using occlude spray. Superb. In the mouth, making sure it fits. And this fitted perfectly. I did not need to adjust it. And then even better, when she occluded, it was beautifully balanced. And because we'd done the mock-up first, we'd assessed it and we knew it was right. This was spot on. Lovely canine guidance, protection from the teeth. There, fits perfectly and comfortable as well. So we've got nice pin dams on the model, clasps, superb, nicely finished, acrylic section at the front there. So here is our occlusal splint, our protective appliance for those heavily restored teeth, and the lovely thin flange replacing that missing tissue anteriorly. Now, the great thing about these designs of denture, this with the backings on, it's future proof. Now, this is a different case, but it shows another patient, and this patient lost that premolar, so we needed to extract that premolar. But because we've got these backings on here, it's been designed with the future in mind. We can add onto the backing. Chris can weld a tag here onto the metal framework, and then we can then glue a new tooth onto the denture. And this means that these expensive appliances, restorations, we can add to them, and they're future proof for a long, long time. But this is Wendy's denture, beautifully finished, a little bit of wear on the anterior teeth. It fitted really nicely. It was really comfortable straight away. No problem with opening the bites either. Canine guidance, comfortable, even occlusion, and nicely protected upper teeth. Those heavily restored upper teeth with crowns and big fillings, all protected. Anterior path of insertion, crucial here for getting this lovely junction between the flange and the tooth, both sides. Big gummy smile, high smile. You know, what we can do with dentures is we can disguise the gum work, and we can just, I think that dentures look better than fixed prosthodontics in a lot of situations. So, and you know, she's now future proof and ready to go. And she was one review, no adjustment, and she's been fine for years as Wendy. Works beautifully. So you might be thinking, what's your standard design, Finlay, for partials? You know, this is if the patient has, and they're not heavily restored, but the teeth are potentially liable to be lost because of periodontal disease, then I would take the backing just on the lingual surface and not alter the occlusion. And we just keep them in intercuspal position at the vertical they're used to. So that's if the teeth are liable to be lost. If the teeth are not liable to be lost, like in this patient here, so for instance, that premolar and that premolar and these two here are unrestored and unlikely to be lost, then I don't have anything covering them. Keep it away. So that's great. Nearly at the end now. Thanks for staying with me. It's great. I love chatting about these things. So I want to share with you now Bert. You may have seen Bert in the past in some of the videos, but I now want to share with you exactly how I made a lower denture fit beautifully. So I'm going to take out Bert's lower 5 front teeth there. They've got periodontal disease and also caries, and they need to come out. This is speeded up. So I inject, freeze him up all the way around, get the teeth out super fast, and fit the full lower and full upper. And I'm going to take out the Optricard now. And I had great suction on this lower. This is a full lower denture. This is a suction I had if you turn your sound up on your devices. But you can see I'm really pulling on that with my fingers, and out it comes. There's no implants or nothing on that. It's just purely the shape of the denture. And this is very much a tribute to Dr. Arbe, he's doing a series of 3 talks actually, which are on Facebook at the moment. They're worth watching. He did one yesterday, and you can, if you search him, look it up, it talks about his process. And Rowan and I went to visit him, and we learnt from him this technique, and we actually just we adapted his technique to what we already did. So it's just like an evolution of what I've been taught. But that's his textbook there if any of you are interested. It's good. It's a step-by-step process. But this is essentially what I'm trying to do. This is Bert's denture, by the way. This is the actual denture of Bert. And in his mouth, look, if you look on the right-hand side, the way that denture fits so beautifully in, the tongue sits on it. We've got a great buccal tongue contact position, BTC, as Dr. Arbe calls it here. Superb. And then we've got the retromolar pad coverage just there, and the cheek and the tongue sitting there. It's fantastic. It works really well. And the way that I did this for Bert was I did a lovely big impression, primary impression, so it's overextended, it's captured the retromolar pad and everything. And then Rowan made me a tray. So this is really unique. This is really good, this way of doing it. And is we've got a first tray. We take an impression of the saddle. Look at that. There. It covers the retromolar pad properly. We avoid the Samaya sinew here. And then we then bring this, so it's 2 millimeters short of the width of the mandible all the way around. That's the design of the tray. You can just look it up. If you look it up on my denture construction manual, it's got all the steps, design steps on the download. But so that's the back there. And then over the top of that, we make a second tray. I've actually got one here because I'm about to do this for a patient at the practice when I get back to work. It's 2 parts like that. They're brilliant, these things. The beauty about this is that I can do the distal extension freehand saddles. I can do those impressions without the front teeth getting in the way of the impression. It's fantastic. So what I do is I put green stick just on these borders here and here and mold it in the mouth, and do all various movements. I'll show you that just in a sec. And then I put zinc oxide on and do the same movements. So we take this to the mouth. Here is Bert. So I'm going to take this out, and here we go. So I push that down firmly and get him to go ooh. That's first. Lick the upper lip, 3. Push the tongue against the lower front teeth, 4. And powerful swallow of water, 5. So we do repeat those, and we do that twice. So it's 5 movements. It's ooh, lick the lip, push against that strut, powerful swallow, and lick the lip. 5 movements. So repeat that twice with zinc oxide. It's good. So we get this impression there like this. And then over the top of that, I take this over tray there, sit it over the top of those teeth like this. It goes into the mouth there, and then we take it all out together. It all comes out together just like that. And it's dead neat. It's great. Locks in together beautifully. So, and then what Rowan does is really carefully goes from that to the final denture, which gives us, basically we've got all that border molded and the teeth didn't get in the way of my impression. And this is Bert at review. 1 week later, look at that. I can get a Lacron carver and flipping push it right up. It's fantastic. I can get my finger on it and it's as solid as anything. He's helping me though with his tongue. It's fantastic. This suction denture effective technique. It's lovely. Good. So that's the talk done. Thank you very, very much indeed. I've really enjoyed it doing this again. It's lovely. It just takes my mind off not being at work. And it's great to just talk dentistry. It's lovely. So I've got 2 more lockdown Tuesdays planned. You'll be able to find these on Facebook. The implant overdentures next week, so that is number 5, and then I've also added in a number 6. I've not actually advertised it yet, but I'm going to do a Q&A on all things removable on the 12th of May as well, at those 2 different times. So just, you'll be able to see it either on my blog or at Facebook there. And then if you've got any questions, you can send that by email as well, because I'm getting loads of questions sent to me, and I've got too many to answer physically. So I want to, and they're often very similar. So I want to just do that Q&A and answering as many as I can. But what I'm going to do now is I'm going to just stop screen sharing. So there, I'm going to bring us back to that, and I'm going to now have a look at the chat and see what's going on here with this. So that is great. So there's Lila Kingston there. Hello, Lila. It's super to see you over in Cork. Now, so we've got from New Zealand and Australia. It's fantastic. Sheffield, Glasgow, Portishead, fantastic. Brilliant. America, Turkey. That's really good. Now, let's have a look here. So, hey, Amelia from Manchester, what's the name of the base material in the tray? That's called Tropicalgin, and it's made by Zermac. Tropicalgin Zermac. That's lovely. So, yeah, someone's answered it for you. Brilliant. Amy has. Thank you. Michael Woods. Hi, Finlay. Do you use a specific temperature of water for your impressions, like ortho, to stop it from being too runny? Or do you just gauge it? Thanks. Yeah, I do, Michael. So for the Zermac material, I just run it cold, and I know how long it's going to take with the tap. So I run it right through, so it's nice and cold, and then that gives me plenty of working time with it. Claire and I, we don't look at the manufacturer's time for setting. We actually just work out how long it takes to set. And then she's got a list of the products and how long it takes for each of those to set. So nice and cold water gives us loads of time. It's fantastic. Mayor Desai. Hi, Finlay. Just wondering what happens in the very first appointment with a new patient. Is it just a chat and then make a treatment plan? Or do you take imps for study model? How do you charge for time for that appointment? Mayor, I don't do any impressions at all at the first visit. But actually, now we've had this COVID thing, I'm starting to think that we need to minimize patient contact and have minimum numbers of visits. So I'm going to, when I go back to work, I'm going to start doing primary impressions, even if the patient doesn't come back, just to reduce that. Now, my first consultation is £150. I spend an hour and a half with the patient, and so it's an hour and a half, and it's a total loss leader, because to actually run the surgery, it's around about £250, £300 per hour, even to break even. So, but I build in with my further costs. If the patient goes ahead with treatment, they make up for that, if that makes sense. So Timesh Carson, could you summarize the method of removing the primary impression from the mouth? Yeah, just really carefully. So if we're talking about Donna, it's just down the long axes of the teeth, getting my fingers around the border of the tray and just wiggling it down those long axes, and then it just comes with that. And just being so talking to the patient. Christopher Callison, where should the post dam sit? I've read the vibrating line, but journals describe this in different places. So for a complete denture, Christopher, the edge at the back of the denture in the middle here, I get it to run across the fovea palatini, right over the fovea. I find that that's a great landmark. It's important to have it extended. The post dam's cut in all the way around the back, all the way around the back there. Download my denture construction manual from the website. It's got it drawn on there exactly. And also, if you look through the 7 pillars lectures, it's on there too. Chris Shazza Hamid, how the posterior occlusion is balanced when canine is in place of lateral. What shall be the contacts on the posterior occlusal scheme? Can you please elaborate a bit about it? So, yeah, Shazza, don't stress about it. It's fine. Seriously, everyone gets so hung up about occlusion. It's so simple. All we need is, when the patient closes together, just even contacts on both sides. Just nice even contacts in around about the 4-5 region. Whether we've got balanced articulation the patient, as long as the denture fits really well, we've got even contact on both sides, balanced articulation is not necessary. That's what I think. And it's about training the patient to become a chopper, not a grinder. To think of it, it's a prosthesis that looks like natural teeth, but does not act in the same way as natural teeth. It's a well-engineered lump of plastic. So balanced articulation, don't lose any sleep about. It's so important to have them well-fitting, good impressions, and even contact. What is your consent process? Timesh Karsan, what's your consent process for immediate dentures, especially considering relining replacement? So it's just as Timesh, it's the consent process is we make the immediates, and part of that plan, the definitives. So all of that fits in. So that's all part of the consent. So a patient does not have an immediate without already going ahead with the definitive. It's all one price together. Very important. Lots of letters, long letter, discussion, talking about it. Michael Conway, did you say you use MIP versus CR in your immediate denture? Yes. MIP immediates. So do you ever take a registration? Timesh says, when making a immediate, Timesh Carson, i.e. do you extract the posteriors first, then make the denture to try-in stage, then take the anterior teeth out and fit the complete denture? No, I don't. I think that the whole process, personally, it's fine doing it like that, Timesh, and everyone's got their own way of doing things. It's absolutely fine. I just like to get that horrid visit for the patient done and out of the way and get those teeth out. It's not a nice visit, and get the immediate in, no messing. And it just helps them to get used to it better. So that's, I prefer it like that. And that's how I find to do it better. But again, it's just, there's lots of ways of doing things and that work. So Ash asked, when using the Visco Gel, is the patient occluding? to get the mold, or do you use finger pressure without patient occluding? Important. That I think it's really important. Whenever I do any sort of impression in a denture, I don't get the patient to occlude, because the patient could occlude and make the denture go like that, and everything sets with a denture like this. I just use my finger pressure, and I want it to seat fully onto the palate, down or down. Tony Bond. Hi, Tony. So do you use alginate mixer or manually mixing the alginate? Is it worth an alginate mixer? Love you. Thank you. Love you, webinars. Greetings from France. Hi, Tony. It's good to have you here. It's great. I love the alginate mixing machine. You know, it spins round. It's a bit like the potter's wheel. It spins, and it means I can push the alginate onto the side and get it to just be so free of air bubbles. It's fantastic. Yogesh Patel, how long does the Visco Gel Realign last? I leave that in, Yogesh, from the point of extracting the teeth for that 2-month period until I come to do my chairside reline. Maya Desai, have you noticed any difference in the amount of retention in full acrylic dentures versus upper full dentures with metal middle? Thanks. Maya, yes. I think the retention of a full acrylic denture is slightly better than a upper full denture with a metal middle. That's what I feel. I don't think it's to do with weight. I just think it's fit. But the advantage, however, it's just the advantage of having a metal palate, I think, outweighs the non-metal because of robustness. I just think it's so good long term. I don't like things breaking. So it's there's always pros and cons, aren't there, to these things. Alexis Isunza. Rowan is in your dental office when taking the first impression, so he can take the hard models, or you send this to his lab in the impressions. What happens with the contraction time of alginate? Alexis, this is a common question that everyone stresses about. You know, when I'm doing talks and things, please, this is really important. Modern alginates now are dimensionally stable for 5 days, and maybe even more than 5 days. That is enough time for that alginate to be posted to the lab even and poured. They're really good. The modern alginates are brilliant, as long as they're looked after though. So please put it into a bag, you know, and put a wet gauze on it, seal the bag, put it into a box with bubble wrap, and so it's looked after and cared for, and it will be absolutely fine. Promise. Laura Borry. Do you find your patients need fixative at any point during the immediate denture process? Yes, I do, particularly on lower falls, fixative, yeah. So, and it's sometimes even with my definitive dentures, fixative is necessary too. It's important, I think. Yeah, Mishari Al Dafiri. I tell you what, you guys are really listening. It's great questions, these. So what makes you decide on whether to use Visco Gel in 50% of your immediate fits? Is it due to the gap on the fit surface and or for comfort? It's to do with the gap, Mashari, and it's the fit. As in, suction. If I put it in and it's dropping down because I think there's a seal issue, then I put some in. And I usually I check as well with silicone first to see what space there is once I've taken the teeth out. Great question. It's for fit. Lee Plummer. Hi Finn, I was wondering why you choose a flangeless design as opposed to the flange in the anterior saddle. That's quite important actually, Lee, because it's flangeless for that little saddle area, because what I find is that I'll take the teeth out, and if we made the flange to fit over the alveolar processes and things, the denture is going to look weird and like massive. So it'll like stick the lip out there. So that's why we socket fit it to start off with. And then when we get shrinkage, I add the flange on. That's my logic behind it, hopefully. So Ash asked, does the UV gel just go on the anterior area where it's resorbed? Yes, it does, Ash. Purely on the bit where we've got that shrinkage, and I don't put it on the palate, you know, that because the hard palates, this bit just doesn't change. Yen Lim, you've asked, for the case with the change in occlusion, did you say you used pattern resin? Yes, it is pattern resin. That's like Duralay, so GC pattern resin. So Ash, you've asked a good question as well. Is the occlusion in centric relation for the metal overlay denture? I did that we mounted the models in intercuspal position using a face bow, and then we just opened the bite up 2 millimeters at the incisal pin. And so because we've mounted it using a face bow there, then we've got the hinge axis in the same position as the patient. So it's in intercuspal position, opened up, and then we made the denture at that increased vertical. So I didn't use CR for Wendy. It was ICP. Mishari has asked again, do you prepare any of the teeth that are overlaid with the chrome splint in the splint design? I didn't actually do any prep actually for Wendy. I quite often do, and this is a really good point, everyone. What I use is, this is a little surveyor that I've had for years. It's a little Japanese one. In the lab, we've got a proper big surveyor. We use a surveyor all the time. Me and Rowan get the models on it. Rowan looks at paths of insertion, the best way the denture is going to fit. And then we mark on the model where I want to adjust the teeth. And then I often just use a diamond just to cut the teeth a little bit, just to adjust them. But because Mishari, Wendy had such flat back teeth, they were really worn, the whole thing didn't need it. It just didn't need any prep actually, so that's quite interesting. Mayar Desai, with the Scandinavian design, upper denture covering the occlusal surface of posterior teeth, does it not open up the bite posteriorly? Thanks. Yeah, it does. The patient it opened the bite up on, it sits onto all of the occlusal surfaces, so it actually opens the bite up on that. Alexis Isunza, do you always use a special tray for your final impression? Pretty much, Alexis. I'm old school with that. I just like them. Yeah. Benita Parshotam. Hi, Finlay. How do you feel about peak dentures rather than cobalt chrome? Would that give better aesthetics for occlusal splint, or is it not strong enough? potentially it's not strong enough. I'd have to thick it. I have actually made a peak upper denture before for a free-end saddle lady who's got upper 3 to 3, and I made a peak, and also I made a metal base one, and the patient much preferred the metal base one because it's thinner and slimmer and felt better in the mouth. But I do take your point, Benita. They do look better. What I want is, if I had a magic wand, I would have a material, denture-based material, that had the same properties of metal, but was tooth-coloured or pink, gum-coloured. That would be amazing. And also, if we could get away with clasps as well, that would be really useful too, metal clasps. But let's watch this space. Do-do. So would you, Anthony Coe, did you prepare guide planes on the mesial of the upper premolars, sorry, 1-4 and 2-4, to work with the posterior clasps? No, it was just that we have that path of insertion there. So I didn't need to do any prep on those anterior teeth. Sometimes I might have to. And again, it's just, I didn't do it for Wendy, but sometimes just using the surveyor, checking the path of insertion, and then we would adjust the teeth if need be. It's a good point. Lovely. How to manage gagging from their dentures. How to manage patients that get a gag from their dentures. So Isabel Fraser. So I tend to find if the patient has a gag reflex, Isabel, that it's generally produced by this extension in the middle here. So I can compromise on this extension by bringing it further forward. But what I don't compromise on is around the back of the tuberosities. So we just swing it further forward there. And the way that I judge it is, obviously when I'm doing the impressions, if the patient's gagging, then I know that we've potentially got an issue. And then when we come to do the jaw registration stage, so we've got a wax rim like this, and I'm prescribing where the teeth are going to go. What I do is, here, I'll trim out this back edge just there to the point where the patient's not gagging. And then we then bring that post down forward on that. So that's how I assess that, Isabel. So Tony Bon, can the cutback tray replace the 2-tray system for the lower mandibular impression when using the cutback tray and when using the 2-system tray? Thank you. So now, Tony, I probably, if you remember, I needed to get, this is for Bert, I did a primary impression, but I didn't use that because his lower, this cutback tray here is designed for the edentulous mouth. And even though it looks a little bit like a stock tray, I wouldn't be able to get it over those front teeth there. So I just used a standard stock tray, lower stock tray in there, and then did that for my first part, and then the second part using the 2 parts. So to be blunt, Tony, no is the answer to that question. So Mayar Desai, hi, when do you use Gothic arch tracing? Is it only for full fulls? Is it always Foutard D for removables? And do you always conform for removables? So I use Gothic arch tracing for both full fulls and for some partials. if I'm reorganizing the occlusion for a patient for a partial denture situation, so say they're like this, they're needing this is a lower freehand saddle, and then at the top they're edentulous. I'll use a Gothic arch for this. It's brilliant for that there. I use Gothic arch tracing for my fulls for implant overdentures and male. But if I'm conforming to ICP, then I use Futar D with wax blocks. It's very, very much case dependent. But generally, the more teeth, natural teeth the patient has, the more likely I am to conform to their intercuspal position. And the less teeth they have, the more likely I'm needing to record CR because there's no intercuspal contacts anymore. And then the wax rims have to be used for recording the occlusion where people have got missing teeth so that we can approximate those. I know, Mayo, I'm sorry I'm making a meal of answering that question, but it's very much case dependent. And hopefully we will explain it in the book better, me and Dr. B. Thank you for those lovely comments. It's absolutely superb. Lovely. That's great. Hi, Judy from Canada. It's fantastic. It's great. We've got all these people from all over the world. It's ace. Doo-doo. Yeah, you could hear a blackbird singing in the background in the garden. Doo-doo. So Michael Conway. Coyce went over a case of another dentist that a patient had an anaphylactic response to red pink Futar. He now recommends using green. The case was complicated because the dentist was going to use diphenhydramine, but the pills were also pink. Just for info. Love you, webinars. Cheers from Vancouver, Canada. Thanks for that, Michael. I'll look into that one. That's really good to know about these things. Miles, like, is your left eye okay? No, it isn't. I've not been fighting, but I went to say goodnight to Oscar, and this is actually Oscar's bedroom, but he's sleeping through there with Zach. I went to say goodnight, and it was pitch black, and Oscar nutted me in the head there. He was fine, but it was just last Thursday, so it's a bit of a mess. So I'm sorry about that. But thanks for asking, Miles. Do you produce a lot of pressure, Aura Gross? Do you produce a lot of pressure when you take the lower impression? Yes, quite a lot. And Tony Bon has asked how many years dentures should be good for. I reckon I would love to replace them every 5 years. But what I find in practice, I've had the referral practice now for 13 years. I'm finding my patients come back 10 years after and have them redone. And I'm looking at my ones from 10 years ago. And because I never stop learning, there's always stuff to learn. We can then improve them. It's just like an evolution of improvement. It's lovely. So, Mayo, how is surveying the model in the lab transferred to the new denture? Mayo, I tell you what, all of your questions are great. Mayo, you are being highly perceptive. It's very, very good. I did a talk yesterday, which you may not have caught, but I showed an immediate case. And quite often, Rowan will make me prep guides if I really need to be precise, and they're like little Duralay hats that we put onto the model, just fit over, and then the bit of the tooth they just fit over like Duralay. A bit of the tooth that I need to cut off just sticks out, so I can then just do a nice little odontoplasty, and it's just like for fixed pros. That's great. So when's the book coming out? I need to get writing. I've got a list on the wall here of how many hours I'm putting into it. That's great. That's lovely. So anyway, thanks very much, everyone. And I hope that you can join me next week for implant overdentures. Have a really great rest of the day, and you all take care and stay safe. And thank you for joining me. It's been great. Really good fun. See you now.